Okay, welcome. We're so happy to be together with all of you today. I'm Rabbi Stephanie Resnick. I'm the Executive Director of the JTS Hendel Center for Ethics and Justice. Later in the call, you will hear from Dr. Yonatan Brafman, who is the Academic Director for the Center for Ethics and Justice. And we're here today with Rabbi Danny Nevins and Dr. Toby Schonfeld. We're talking about COVID, triage, and Jewish ethics. We're so happy you're here. We are recording and we will send it out afterwards if you want a second opportunity to hear the wisdom today and take it in and share it with your friends. We'd love for you to share it. The Hendel Center for Justice and Ethics explores the intersection of Jewish activism and scholarship. We teach classes internally at JTS on ethics and justice. We have a certificate for people who are working in the field of social justice who come to JTS to learn about Jewish social justice and activism, blending scholarship with the activism that they're already doing out in the world. We work internally at JTS on issues of justice. We work in the neighborhood of Harlem, Morningside Heights, the Upper West Side, where we are living and working, modeling the intersection of activism and justice. And we also work out in the Jewish community. We have been around for about a year. Sometimes we put on public programs like this. Sometimes we have workshops. We are open to ideas and partnership. So if you have ideas, please feel welcome to share them with me because we're just getting started and we have lots to do. You probably got to see the bios when you signed up for the webinar. So we have esteemed panelists, and I'm not going to read everything they did because I want you to be able to learn from them directly. But I will simply say that Dr. Toby Schonfeld is the Executive Director of the National Center for Ethics in Healthcare and also a member of the CJLS, the Community of Jewish Law and Standards of the Rabbinical Assembly. She works at the VA, and if you get her going about the VA, you will feel so proud of the work that they're doing and so happy that she's working there on ethical issues. Rabbi Danny Nevins, I get to work with him every day as the Dean of the Rabbinical School, where I'm also the Associate Dean, and it is a great joy to do that. He also is on the CJLS, the Committee of Jewish Law and Standards of the Rabbinical Assembly, and has written many important responsa. He wrote one on COVID and triage, which brings him here today, but he also wrote many responsa that have helped shape who can become a rabbi today and who is part of the Jewish community. So look up his work if you haven't encountered him before this. And Dr. Yoni Brafman is a beloved professor at JTS, somebody who people who want to learn about ethics are constantly seeking to learn with. So his classes are robust, and he will moderate the conversation, so you'll hear more from him later. So we're going to start with Dr. Schonfeld.
Great, thanks very much. Can everyone hear me? So I see some head nods, so we're good. So thank you very much for the invitation to be here today. Just a quick disclaimer is that nothing that I'm presenting is official views of the Department of Veterans Affairs or the US government. I have to start with that disclaimer. My preferred pronouns are she, her, and hers. So if that comes up in conversation later, so you know how I like to refer to myself. But today, what I want to do is set the stage for the conversation that we will have with Rabbi Nevins here in a few minutes about the Jewish part of the response to the COVID response. So my job here is to set the ethics stage, and I'm going to do that by sharing my screen. Let's make sure this works. If one of the panelists could nod their heads, if you can see my, okay, great, thank you. You're the only people that I see, so this is very useful. So what I want to do today is really just set the stage for how we're going to think, how we think about some of the ethical issues that come up in the treatment and management of this global pandemic. I couldn't possibly introduce or address all of the issues that have arisen in the 15 to 20 minutes I have. So what I've tried to do is pick and choose those that I think are the most salient for us, the ones that help us have the most useful conversation and to help sort of frame our thinking a little bit about what we're experiencing and what's going on in the world. So the first place to start, I think, is by thinking about the framework with which we are operating. And by that, I mean, we are shifting the way we look at and address healthcare from how we go about usually. So in a normal situation, the goal of healthcare really is individually patient-centered, right? So we figure out what in our case, this patient in the bed, what would most contribute to that patient's well-being. And one of the values that you may be familiar with that we celebrate in ethics is respect for autonomy. The idea there is that an individual is the authority on what her values, goals, and priorities are. And so a physician can help to make a recommendation about treatments, but it's really the individual who gets to make the choice and say, this set of burdens is too great for me, this benefit is appropriate. So this is the course of treatment I want to have. What happens in a global pandemic like we are experiencing now is that the goal shifts. So we shift from maximizing the benefit of each individual patient to essentially enabling us to achieve the greatest possible benefit for the greatest number of individuals, while at the same time excuse me, maximizing respect for human dignity and fairness. Now that piece, I think Rabbi Nevins is going to speak to in a little bit, that matches very well what our Jewish values are. But for those of you who are familiar with some of these philosophical concepts, we call this a bit of a modified utilitarian approach. So a utilitarian looks at sort of greatest good for greatest number, without thinking of sort of other considerations. That's not what we're trying to do here. What we're trying to do here really is to maximize benefit, but recognize that there may be some boundaries and limits there. So what that means and how that changes care is that instead of us focusing on what this individual patient needs, we have to take a broader perspective, and that what that results in is often some boundaries, some different limitations to healthcare than we've seen in the past. So what are the values, the ethical and professional values that come to light during when we're thinking about public health ethics, and in particular when we're thinking about things like triaging a scarce resource? There was a review that was published a few months ago, which now seems like ages ago, in a professional medical journal, where what they did was they looked at a number of triage policies at some major institutions. And these are essentially the 5 values that were the most commonly cited in these policies. So these are essentially policies across the board. So some of them aren't that surprising, right? Justice. So in that sense, if we're thinking about triaging a scarce resource or trying to make sure that the right people get whatever the scarce resource is, we have to make sure that whatever our allocation is that it's applied consistently and broadly and fairly. Now, how we do that, we'll talk about in a minute. Transparency is a really important value when we're thinking about public health, because as I think we've all been sheltering at home, we've been very hungry for information. We want to know, how are decisions being made? What is the information? How is that being communicated to us? So being clear, being transparent about how we're making decisions is very important for an engaged public and to advocate for trust in the healthcare system. We do have to make sure that whatever these resources are being used well. That's true because they're scarce, but that would be true even if they weren't scarce, many of us would think about. And so what is our responsibility to be good stewards of resources, and how does that work? In a global pandemic like this, we think about a healthcare provider or a system's duty to care, and we think about making sure we're caring for those COVID patients and getting the right materials to the right individuals. But sometimes there are individuals there who when we make these triage decisions, may not qualify for a certain intervention, so may not qualify for a ventilator or something like that. Our duty to care does not go away regardless of those decisions. In fact, our duty to care in some senses is amplified by our responsibility to make sure that we do not abandon patients and that we continue to provide all the normal care that we might otherwise. So comfort care or other optimal clinical outcomes, even if they don't get a particular scarce resource. And this final duty to protect unnecessary loss of life, some individuals would simply call this the duty to plan. And so there are a number of sort of think tanks and other bioethics groups that have come out with an important piece of our response is actually thinking about things in advance. So many of us are working from guidance that actually wasn't even originally developed for COVID, but was developed for H1N1, right? So several years ago, we might remember that there was a concern about pandemic flu. The issues were very similar. It was a communicable disease. We were concerned about social spread in the same way that we are now. There isn't a cure, right? So the idea is we want to prevent people from getting it. And so by using planning documents that were developed for a previous infectious disease, we've been able to apply many of those lessons. That's one of the benefits of a duty to plan, is that it gives you the opportunity to think through what would the fairest things be in a given situation. So what are we talking about here when we're talking about ethical issues in triage? So triage, while it's getting a lot of press now, it's not a new concept, right? Triage is something that happens in every urgent care center, in every emergency room, certainly on a battlefield. The idea behind triage is that it is simply a clinical strategy for optimizing the use of resources that are insufficient to meet the needs of all patients. This can be as simple as an emergency room that has 10 patients and there are only 2 physicians on duty. You have to find some way to prioritize who gets to see the physician first, right? So that's one kind of triage. We're talking about a slightly different kind of triage here. It's a different level of triage, where we're talking about decisions specifically about the allocation of scarce, life-saving clinical resources like ventilators, intensive care unit beds, medications to use those who are to treat those who are gravely ill from influenza, from COVID, from other illnesses, right, that we may have issues with. And in the instance of dire scarcity, where the need outstrips demand, we have to think about what are the ways that we think through who gets what they need in order to survive. Now, this is where I start to be able to just give you some high-level insight into how we make some of these decisions. So let me give you a couple of things that groups think about. Again, this comes from the literature about a survey of what are the most common criteria that are used in these policies. So the first is the criteria of benefit. So we only want to give a life-saving resource to someone who might benefit from it. If there is going to be no benefit, then in one sense, it's a wasted resource, right? So what do we need to know in order to know who might benefit? Well, the first thing we need to know is what their prognosis is. So hence my artistic image of a prognosticator, right? A fortune teller. Now, we like to think that medicine is much more advanced than this. We're not quite as good at prediction as, or at prognosis as we'd like to be, right? But we are more scientifically advanced than this. But the idea is that most of these policies are looking specifically at short-term survival, and by that we mean survival to discharge from the hospital for this particular event. And so those individuals who would need a certain resource, we can be talking about a ventilator, we can be talking about an ICU bed. Those who are most likely to survive to hospital discharge is one category. Others use longer term survival. So I've seen policies that have said likely survival for 6 months. The idea there is that if the patient already has, let's say, a terminal illness, so terminal cancer, and they are hospitalized because of COVID, is it the best use of the resource to give those patients who are likely to die soon, apart from COVID, that scarce resource? Others say that shouldn't factor in, that the longer term, the 6 month, the year, that sort of thing actually is discriminatory. It discriminates based on age, it discriminates based on other healthcare conditions. And so you shouldn't use anything beyond discharge from the hospital for this particular issue. And so I also want to make clear that this is not a settled situation, right? So So there's lots of debates about what we use for prognosis. There are more commonly used clinical scoring mechanisms, criteria, and then there are lots of criticisms about those as well. We don't really have time to get into those, but there are clinical mechanisms that enable us to engage in this. A second criterion is, so we looked at benefit, we also need to look at need. So there are individuals who might survive even if they're not given this life-saving resource. Some might say that those people don't need this resource as greatly as someone else. So when we think about need and we think about who we prioritize, one question that comes up frequently is, should we prioritize healthcare workers? And so hence my artistic representation, that's Maimonides. I often use images. I think they help us remember what we're thinking about, right? And why would we think about prioritizing healthcare workers? Well, a couple of reasons, right? So some have said, well, listen, you know, if they can help us respond to the pandemic in the best possible way, right, get back to work and help us address the pandemic, then that might be the first thing that that we need. Those healthcare workers often bear the greatest burdens and sacrifice the most. I think one of the challenges, though, is that one of the things that we're learning through this pandemic is that there are others who are also providing great, who are engaging in great sacrifice, right? And so how we weigh those, right? How you do that prioritization can mean anything from being placed in the highest priority group to being given special consideration, that sort of thing. So another criterion is the conservation of resources. We've already talked about stewardship, and so that comes into play here. That's a ventilator machine, right? And then the question is, suppose that there are people who on the scoring mechanisms come out exactly the same. So they have exactly the same chance of surviving to hospital discharge. Their decrements and breathing, that sort of thing, are exactly the same. How do we decide? So many of these policies use a lottery method, hence my little raffle ticket here, as a way of deciding which patient then gets the life-saving resource. And why is that? Why use a lottery rather than something else? One of the things that people are very concerned about in this pandemic is allocation of resources fairly. And when we think about fair allocation of resources, we have to be very conscious of even and often unintentional bias that creeps into our allocation schema. So under the pressured conditions of a pandemic, health disparities can be increased. Disadvantaged communities can have delayed access to testing, problems with transportation to healthcare facilities, lack of insurance, worry about immigration status, so they won't present to the healthcare facilities. So these are all reasons why doing a first come, first served approach to allocation of resources may not be as fair as a lottery approach to resources. Another example of issues, a lot of times when we're thinking about response to disease, we're thinking about being in an urban environment. Like, here are all the drive-through testing facilities in my county, for example. What if you live in a rural area, right? What if you only have access to one hospital, or what if the doctor only comes around once every 3 days? How do we provide care and resources for those? Other things that have come up have been maternity policies, who can be there when you give birth to a child, visitation policies, who can be there at the end of a life, right? We've seen all of the heart-wrenching stories on the news of nurses who are there holding the hands of people who have died because their loved ones can't visit with them, right? So there are a whole host of ethical considerations here. So the question then is, who makes these decisions about who gets the scarce resource? This is a drill, right? There is no emergency here. The Virginia Railway Express actually is a local commuter train where my husband and I used to live. This is a disaster drill, but this is an example of triage, right? In the terrible event of a railway accident, in this case, the firefighters will triage those who are wounded, right? This is like what happens in battle, right? And somebody has to say, these people need care first, these people can wait till later. They would be called the triage team. And each of these facilities, each of these hospitals during COVID pandemic should have a triage team. And the triage team assesses the patient's condition, notes where the patient falls in terms of their clinical situation, and gives them the appropriate priority score based on the algorithm. So how do they get the algorithm? The algorithm is decided in advance by something called a scarce resource allocation team. What's really important and why I chose a stock photo of a boardroom is because, and these decisions about how we allocate a scarce resource should not be made at the patient's bedside. These are macro level decisions. These are community level decisions. These are institutional decisions. So what we need, the ethical, the fairest way to do this is to be thinking about what are the criteria more broadly, and then have a different team who makes the decision about, or who implements that. Even the triage team should not be composed of that individual healthcare patient's provider. The reason is because that patient's provider should still be focused on maximizing the benefit for that patient. There are different considerations when we think about allocating a scarce resource and which of the teams should do this. And we can talk more in the question and answer session on the scarce resources. I'm noting my time, and I want to get to 3 emerging issues because I think they're really interesting for us. So the first is, some of you may have seen this. I took this from, again, I just moved away from Virginia, but this I took from the state of Virginia's website. So Virginia is one of the states that has implemented essentially a tracking app, right? So this is a notification app about COVID in your area. Why are we even thinking about tracking apps? Well, think about it. Self-isolation, these lockdowns provide 2 major challenges. For the first, it's severe rights restrictions on individuals, right? Second, there are economic, social, psychological costs to self-isolation, right? As well as the cost of platforms like Zoom that go down when too many people use them, right? And so the idea is we want to get a handle on the pandemic, but we can't just go back to business as usual. And so using an app, a tracking app, might help us get back more quickly. The challenge is there are a number of ethical issues involved in the use of these apps. For one, effectiveness is an open question. There would need to probably be something like 60% uptake in a general area in order for this to be effective. And even if 60% of the population would want to do this, it's not clear that everyone has the ability to, right? There are technical problems. Some apps don't work on phones that are even as new as 2 years old. There are a whole host of privacy problems. There are also inequity problems, right? About who has access to a cell phone and who has access to the data. So there are a number of ethical concerns with using tracking apps. Some of you may have heard about challenge studies. So there are a number of research projects going on to try to figure out what an effective treatment would be for COVID-19. One of those paths might be challenge studies. In a challenge study, what happens is that we give an individual the proposed treatment, but we also expose them to whatever the pathogen is. So a simple example is if we are trying to test a pesticide, so we want to make sure that we're not getting bitten by mosquitoes. You could spray your arm with mosquito repellent, put it in a box, I've seen this done, and then put a bunch of mosquitoes in there to try to bite you and see what happens, right? So on a tiny scale, that's what a challenge study does, is it exposes people to pathogens. The reason people are thinking about doing it is they involve fewer research participants, they're cheaper because of that, and they can determine pretty rapidly whether or not a vaccine is effective. But there are a number of ethical issues with this, not the least of which is it's unclear how an individual could give truly informed consent to participate. since we don't actually have all of the information about the virus itself and what it causes. So originally we thought this was just a respiratory ailment, right? And now we know that there is likely damage to the kidney, circulatory system, and the heart. Initially, it was believed that children couldn't be sickened, they could just be carriers. Now we know not only can they be sickened, but there's a secondary complication for them, right? So we are learning more all the time. So it's very difficult to know what someone would be signing up for to join one of these trials. In addition, it is common to offer payment for participation in these trials, and the payment would likely be significant. That leads to the possibility of exploitation, is that the people who might sign up for this are the people who most need the money, and that would be an ethical issue. Finally, once a vaccine or many vaccines are developed, we need to figure out how to distribute them ethically, because there will not be enough vaccine for everyone, at least not right away. And so we've got to figure out who gets it first and how. And there are a number of schema out there. Hopkins just came out with one last week. There are a number of others that came out earlier for flu vaccine that might be illustrative, but we need to think very carefully through vaccine distribution. My takeaway message is triage isn't new. And it's hard, right? It's hard in the emergency room. It's hard on the battlefield. It's hard in the ICU when it comes to COVID. Reasonable people are going to disagree about this, and it doesn't mean that they're bad people, right? There are a number of ways to approach this. The moral life is messy. I think what we need is simply a lot of thinking people thinking hard about this, right? With as the next piece says, attending to our core values. We've got to be thinking about applying whatever system we come up with fairly and consistently, recognizing that we will likely have some moral distress, right? I mean, part of the reason that you saw a newscast of the nurses crying is because they thought it was unjust that family members couldn't be there to hold the hand of their dying loved one, right? And that it's really important that we retain our empathy, compassion, and humanity through all of this. Let me stop sharing so that Rabbi Nevins can take over.
Thank you very much, and what a tremendous presentation from Dr. Schonfeld. As you understand, we're both members of the Committee on Jewish Law and Standards, which is the Rabbinical Assembly's body. It's a deliberative body for discussing difficult religious questions. And there are 25 rabbis on the committee, but we also have 5 experts who are not rabbis, but are coming from other fields. And Dr. Schonfeld, being a bioethicist, just plays an essential role, not only on bioethics topics, but on all topics, bringing sort of the clarity of perspective, mastery of the literature, academic strength, but also practical strength, as she works in such an important capacity for the VA with, I think, 140 centers around the country. Is that the number you said? I believe that was it. And serving a vast number of Americans. So thank you. And even in today's presentation, I'll be sharing one article that I didn't know about until Dr. Schonfeld said, "Did you see this yet?" And of course I had not, so I'm grateful for her leadership. I also saw the 2 comments posted on the chat. I may be able to get to some of them along the way. I'm going to dive right in by sharing my screen now. So here we go. All right. And this is a last minute addition, the little graphic there of the cheerful little crowns that we've got. Terrifying. And I should say that I'm actually a COVID survivor. I was sickened with it in early March, and thank God was not required, didn't require hospitalization or anything like that. But it is something that I think we're all aware of having a huge impact on our lives. If not your life individually, then loved ones or friends or neighbors. And obviously it's affecting all of us as we try to avoid getting ill. So Dr. Schonfeld already said this much more deeply than I'm going to, but, and as she noted, triage decisions are an everyday occurrence. Every ER in the country is and every urgent care facility is making triage decisions between the person coming in with a cut finger and the person coming in with a heart attack. And so there's constantly going to be a question of who deserves the attention and who can wait on the couch for an hour or more while other emergencies are cared for first. But what's distinctive about the pandemic are some things that what Dr. Schonfeld was just saying about allocation of PPE and eventually vaccines. And she didn't focus on this, but one of the questions has been who gets these? I mean, there are people about, she mentioned the Hopkins study, which I haven't read, but you could say, well, it's going to be the most at-risk categories. But what about frontline workers? PPE, I think we would all agree, should be given to the doctors, nurses, ambulance workers, EMTs who are interacting with people who are ill, because they're able, therefore, to do the job and save lives. Whereas others, especially early in the stage when we couldn't even get masks, you know, maybe we could just sit at home and we don't have to go out, and we don't have to take the N95 mask supply up and prevent the medical staff from having them. And that could also be true eventually with vaccine distribution, that you want to vaccinate people, healthcare workers who are going to be interacting with people who are sickened with COVID so that they can continue to do their job and not become sick themselves. However, there's another level of triage, which is sort of post-infection. And there are some people who have argued that we should allow physicians and nurses and other healthcare workers to be given priority in treatment once they are sick, even if they're not likely to go back to treating patients anytime in the near future. So what's that about? And in essence, that's about morale. It's about helping these healthcare workers feel like the system has got their back and that their sacrifices will be rewarded. However, and that sounds good, but in a Jewish context, and we'll see in an Israeli context, once a person is ill, we have to treat all people equally, because otherwise, if we start to create a ranking system, a hierarchy based on how valuable their work is to society, once they're already sickened, then it quickly gets into many sticky ethical quandaries, including who goes into these professions, and are they in a good representation of the broader society in terms of socioeconomic, racial, ethnic, and all the other disparities. So, and also, if you want people, like Dr. Schonfeld said, to have trust in the system, but you're saying, well, we're going to take your grandmother off the ventilator because Dr. So-and-so is sick and we've got to take care of Dr. So-and-so, how are you going to feel about the healthcare system? And of course, given the disparities based on race and ethnicity, if it played out that a white physician was given priority over an elderly Black patient, that would add further demonstration of the inequities of our system. And so we have to be sensitive to these allocation of scarce resources. Another question, and this I really only became familiar with this week, was balancing risk to the patient versus risk to the medical team. So the New Yorker this week actually had an article about different methods for putting the ventilator tubes into the person's lungs and down their trachea. And the normal way is to thread it down through the throat. And in order to do that, the person needs to be heavily sedated, actually put into a medically induced coma, which has a lot of complications. It would be better actually to open up the trachea and to create a tracheostomy so that there be a hole. And that way the patient would not have to be medically comatized in the same way. However, that method is very risky. It involves a spray of all sorts of viral materials, including from the mucus and blood and saliva. And so the question is, whose health is going to be prioritized here, that of the patient or that of the medical team? As this article by Zachary Helfman said, in Israel, they actually did a study that showed that this procedure sprayed even heavily protected medical workers there with the virus. And so that's another level of triage decision where you're saying, should we do one protocol or another protocol when the the risk to the patient is lower with protocol A, but the risk to the healthcare workers is lower with protocol B. How are you going to make that decision? Another question, which is really the main one we've been focusing on, is choosing among patients about who gets priority in specialized care, scarce equipment like ventilators and dialysis machines, the attention of the specially trained staff. And how far do you go with this? There's a pre-treatment question. I've got 2 patients before me. Who do I treat first? But what about if you've got a patient already in treatment, already intubated? At what point can you extubate them even without their consent and say, look, you're a goner, your relative is a goner, we're going to extubate them and use this machine for someone else. And so those are really 2 different levels of ethical question. And then finally, emergency spending to protect public health versus other pressing needs. And I think David Milgram asked, one of those pressing needs might be the economy. To what extent do we want to maximize health when, if the economy is in free fall and people are having trouble avoiding becoming homeless and putting food on their table, that also is a public health challenge. And so how are you going to balance the needs of this specific virus, of treating this specific virus and preventing people from becoming ill from it, against other economic needs? Many people have said, of course, it's in a way a false binary, because if you don't control the virus, then you're not going to be able to accommodate the economy either. But it is a complicated question. Just one more slide about sort of general ethical questions. So Dr. Schonfeld spoke a little bit about utilitarianism versus a more sort of justice-based or duty-based concept of ethics. The fancy word is deontological ethics, where you say we have a duty towards this particular person before us. And that duty could come from a universal philosophical system like Kant's categorical imperatives, or it could come from a religious source like the Bible. The Bible says, Lo ta'amod al dam re'echa, don't stand by while someone dies. That's a duty. Lo tirtzach, don't murder. That's a duty. And so you could say that my ethical analysis will be dependent on what my duty is to the person before me. But other people will say that might be what you do in normal times. But in a pandemic, it's not normal times. You can't meet your duty, your obligation to every individual. You have to broaden your gaze, and you have to look at the needs of the many. And as Dr. Schonfeld said, you don't want to make that determination at the bedside, because you want the practitioners to give priority to their own patients. That should be sort of a sacred bond in a secular sense. And so that's why they have triage teams that work on the meta level, setting policy for the institution and creating categories and score categories so that a person who meets certain criteria will be treated and a person who doesn't will not. However, this utilitarian analysis, which seems, I think, intuitively correct to a lot of us, nevertheless is quite complicated. You may have heard of Dr. Ezekiel Emanuel, a very prominent physician and medical author. And he talks about not only saving the most lives, but the most life years. And if you're focusing on saving the most life years, well, the 45-year-old patient versus the 65-year-old patient, by treating the 45-year-old with priority, you're more likely to have a longer lifespan. But the truth is, who can really know what's going to be a year down the pike or 5 or 10 years down the pike? Is that a reasonable approach? Emmanuel thinks yes. I'm going to show you that Judaism says no, even though he's a proud Jew. One of the problems with Emmanuel's analysis, which Dr. Schonfeld also mentioned, is that when it comes to vulnerable populations like the elderly, but also people living with disability, the utilitarian analysis might really zero in on them in a negative way. People living with Down syndrome, for example, often have a shorter lifespan. And if you're going to give a purely lifespan type of analysis, then that might mean that you're going to be helping people who are not disabled with a syndrome like that. And people with disability might find that their lives are devalued more than they already are in our society. And so So Judaism is going to put a lot of asterisks on this utilitarian analysis. So Judaism is aware and sensitive to consequences, but we skew much more to an analysis of our duties. And it's not that we don't believe in consequences, but we believe that somehow the larger consequences are out of our hands. God wants us to take care of doing that which is right and just in the micro level, and God, in a sense, will take care of the macro level. At least that would be a traditional Jewish perspective. Okay, saying that, let's look at some traditional Jewish perspectives. Here are a couple of slides with different rabbis who've written topics that are relevant to what we've got here. Rabbi Yechiel Yaakov Weinberg, known for his commentary, his responsa, which are rabbinic letters on complicated topics. His main collection is called Sridei Eish. He was a survivor of World War II. I believe he survived in a Russian detention camp because he was a Russian citizen. But nevertheless, he writes with a perspective that's aware of the Shoah, and he lived, I believe, at the end of his life in Switzerland. In any event, he says here that life is the ultimate and clear value. It's not subject to quantification and assessment, even if many lives can be saved only by murdering one person. Murder is absolutely forbidden with no limit or a condition. And there's like one story in Jewish history of a town that comes from the book of Samuel, and about a town where there's like an outlaw that's being sought, and a siege is put around the town, and they say, just give us this guy, Sheva ben Bichri, and if you give us him, then we won't kill the rest of you. And they do. They hand over this criminal, this outlaw, and then the rabbis wonder, well, is this therefore a basis for the idea that you can sacrifice one to save the many? And they put all sorts of qualifications on that story so that it really cannot be used on a utilitarian basis to say that you can quantify life. And this statement by the Sridei Eish is really a much more traditional Jewish perspective. Here's another perspective, a slightly earlier rabbi, Yosef ben Meir Ta'omim, one of the commentaries we have on the Shulchan Aruch, the great code of Jewish law from the 18th century. The commentary is called Pri Megadim. And he speaks about a case where you've got one person in certain danger and another in possible danger. And in Judaism and Halakha, Jewish law, we generally say, if it's a case of maybe versus definitely, definitely always has priority. So if you know for sure that person A needs to be intubated, to be ventilated to save their life, whereas person B, maybe, they might get there, but we're not there yet, then you take care of the person who's certainly ill. But can you also extend that in the other direction? Two people definitely need to be intubated. One person may be savable, and the other person may not be savable, right? So at that point, do we also say that the certain has priority over the possible, right? So he doesn't go into that direction in this case, but we're going to now skip to a 20th century rabbi known as Rabbi Moshe Feinstein, who was an American rabbi in Brooklyn, and his collection is called Igrot Moshe, the Letters of Moses, or Igros Moshe, and here he names a couple of important principles. It's a long text. I'm not going to read the whole thing, but I'm just going to point out that he gives this idea of a sort of a prognosis of 1 year. Now, Dr. Schonfeld mentioned 6 months, and it's true that in a lot of the medical literature today, people speak about survival on a 6-month time frame, although I've seen some medical journals that also mentioned up to a year. The reason a year is important is because in classical Jewish sources, we've got an idea of a treifa. Now, many of you know that non-kosher meat is called treif. Well, why is it called treif? Because if an animal has been mauled or injured, or it's diseased in some way, it's considered treif. That means like it's literally torn, and it's not going to survive. And if it's going to die of natural causes or even of attack, then you can't consider it kosher. Well, there's also a treifa law for humans, not to be eaten, God forbid, but rather that if somebody is already terminally ill and they're in the dying process, and something is done that accelerates their dying, that might be wrong, but it's not necessarily murder, right? Because they're already considered to be compromised in their health. And so Moshe Feinstein says that if you've got two patients one of whom is terminally ill for another cause, right? They are already expected to be dying this year, and then they got COVID, right? And we can't heal them from the first cause. Then should you treat them for the COVID with a ventilator, or should you give that scarce ventilator to another person who has a prognosis of more than 1 year? But then having said that, he says, but you only go so far with this. When the doctors say, well, they might live 2 years, they might live 5 years, they might live 10, that's not relevant anymore. The only thing that's relevant is, are they actively dying now? Do we expect them to die the next year? And if not that, then you don't consider it otherwise. Now, he mentions toward the end of this passage that, let's say all things are equal. We got 2 patients, they're both in need, they both could survive more than a year with treatment. Then what? He says you do first come, first serve, right? And that is a very defensible and traditional moral standard. Or he says closer to his home. Here he's writing aware of a pre-modern context when physicians often were working out of their home and they were mostly doing home visits. And so if a messenger comes to Dr. So-and-so and says, oh, there are 2 people who need your help, doctor. They're both very ill, and one lives down the block and one lives across town. The doctor probably should go down the block and get to the person that they can treat fast, and then hopefully they'll have time to move on to the other person. By the way, this is not uncomplicated, and Dr. Ezekiel Emanuel says that maybe we shouldn't give priority to people on a first come, first served basis. Perhaps just because they live near a hospital, that would discriminate against people who live in a rural setting where there aren't local hospitals, for example. Or perhaps it might discriminate against people who wore the masks in there and took more precautions and didn't get sick in the first wave of illness, but only in the second wave, right? But even so, I think in this case, you treat the person who's before you. They create an obligation. If you think about the great philosopher Emmanuel Levinas, who speaks about the person before us being like the face of God and imposing upon us duties, then once you have a person, you can't say, well, who else do we got? This person needs your care. You have to care for them, unless they're clearly dying, in which case you're going to have to move on to the next person that you can rescue. He mentions, Mishnah Horayot over here. That is a complicated text. It's a text of Mishnah, which seems to imply that you can prioritize different categories, save men's lives before women's in certain cases, and women's lives before men's in other cases, and maybe the priest before a regular person or a sage before a priest. And it's a big mess, this whole hierarchy. And the rabbis have basically said, you can't use this category. And I've got many, many proofs of rabbis saying that thing at the end of Horayot is just not a usable text for us. And even Moshe Feinstein says, if all else fails, you might give priority according to Mishnah Horayot, but if that's not known, which it won't be known, then the lottery, which again, we've heard about from Dr. Schonfeld. I'm going to give you one last rabbinic text. This is Rabbi Menashe Klein, who was a Ukrainian rabbi, and I think at the end of his life lived he moved to New York and then to Israel, I believe. So his response are called Mishnah Halachot. He says that if, in his humble opinion, if you had started treating one person, right, but they cannot be saved even with this treatment, and another more viable patient comes, you can actually extubate them and give the resource to another patient. And this is something that's actually quite controversial. It's controversial in the Jewish community, and it's also controversial in Israeli law. So just a couple weeks ago, this paper came out, and in the journal Rambam, Maimonides Medical Journal in July, and this is the journal that Dr. Schonfeld sent me. And there's a dozen or so authors, including Dr. Avram Steinberg, who's a very prominent bioethicist in Israel. And they emphasized in this that in pandemic ethics, you have to retain your sense of basic equality of all humans. You can't discriminate based on their abilities, and you can't discriminate against non-citizen residents of Israel, including Palestinians. And it's very important that an Israeli medical journal with an Orthodox rabbi as its lead author is demanding that that priority not be given to Jews over non-Jews. And they actually cite the famous Mishnah from Tractate Sanhedrin, chapter 4, Mishnah 5, about whoever rescues a life, it's like they rescued a whole world. But of course, that Mishnah says whoever rescues a Jewish life, but they don't mention that part, and they make it seem like all lives are equal, which of course they are and should be. They mention what Dr. Schonfeld also mentioned, that during an emergency, you have to shift your attention to the lives of the public as a whole, sometimes at the expense of individuals, but your principal rule is always to save as many people as possible based on medical data for that patient and not on other things like who's meritorious, this person won a Nobel Prize, this person has a large family to feed, or anything else like that. It's just the medical information about that patient. They came to a no decision on discontinuing fetal ventilation therapy, right? Unlike Rabbi Menashe Klein. They said, we debated it, but we decided we're not there yet. We've actually got enough ventilators in Israel to treat the people. We haven't gotten to this horrible place of having to rip out equipment from one person and give it to another person and cause the first person to die. So we're not even going to rule on that because we didn't come to consensus. And finally, they emphasized that chronological age, disability, merit, negligence, like if you said, well, this person was a smoker, so they've got a higher risk because they made bad decisions in life, or they're obese or something like that, which has a higher risk association. You can't discriminate based on that, only based on can this person be saved now to discharge. So finally, there's my paper, which was for the law committee, was passed in May, Triage and the Sanctity of Life. I came up with 5 conclusions, and with them, I'll conclude this presentation. Number 1, I conclude that equal access to medical care is a moral and halachic imperative. Triage decisions must not be based on criteria other than the best chance to save lives. 2, scarce resources used to prevent infection may be assigned on a priority basis to medical professionals, right? In order to support them in their life that's pre-infection, you can give priority to medical professionals. On the other hand, Jewish law differentiates between brief respite, chayei shah, and recovery, chayei olam. So scarce medical resources may be directed toward patients who are expected to recover over those who are not expected to recover. And this sequential organ failure assessment is or SOFA is a protocol that's mentioned by he and White, I believe. I'm sorry, Lowe and White, one of the prominent articles about triage assessment in American literature in JAMA. 4, if a patient is already receiving medical therapy, is responding, they may not be removed from the equipment prematurely in order to rescue the life of another person. The only criterion for removing a person from therapy is a determination that they cannot survive to discharge. And then 5, if the triage officer determines that a patient cannot be saved and that their medical resources must be reallocated, the basis for the decision must be explained fully and sensitively to the patient or the representative. This is the so-called transparency. And the hospital must continue to support the patient with appropriate palliative and pastoral care until the end. Okay, I'm going to stop screen sharing. And I think I probably used up my time. So I'm going to turn it over to Dr. Brafman now, and we'll look at the Q&A and have our conversation.
Great. Thank you so much to Dr. Schonfeld and Rabbi Nevins for such informative and rich discussions. Right now, I want to invite our participants to formulate questions and enter them into the Q&A. And in a few moments, Rabbi Resnick will draw from those in order to present them and get some answers to you. Before that, though, I want to pose a general question to both Dr. Schonfeld and Rabbi Nevins, really thinking about it from their different, perches, working in the government, at the VA, working at JTS. And this is about the relevance and applicability of religious traditions to public policy. I was struck by, this is a paraphrase, Rabbi Nevins, you said, we have to focus on our individual duties, and God will take care of the macro level. So to put it in the most provocative way possible, one could argue that politics is precisely taking care of the macro level, and engaging in that involves not leaving things up to God. So I see that as kind of typifying kind of this challenge of kind of what are the relevance and applicability of the religious traditions for formulating public policy in this moment of pandemic.
Well, maybe I'll start because that last part was directed at me, but I'm sure Dr. Schonfeld has thoughts on that too. I did say that was like a traditional Jewish perspective might be, that there's this idea of bitachon, that you trust that God will sort of make things even, and not only on the macro level, but even on the micro level. That's why sometimes we have trust that we can do the right thing, even if there's an opportunity cost. To give a trite example, I always remember the beginning of the school year when I was in college, being very anxious about taking off days of class to go to Rosh Hashanah and Yom Kippur and Sukkot and Shmini Atzeret. And there was a piece of me that thought, I'm really going to be in a big trouble. Another piece of me thought, do your best, and you won't be penalized. It'll be okay. So that was my level of bitachon. But it's not that, obviously, that Judaism doesn't want us to think about the larger picture. It doesn't feel that we have responsibilities that are broader. The Torah itself speaks about doing that which is right and good, and then God will bless the land, as we have in multiple places in the Torah. And in fact, there's almost the opposite, that when you do something individually meritorious, it can have an impact on the broader world. Maimonides, as we all know, we're in the month of Elul, says a person should look at themselves as evenly balanced between merit and sin, and should look at the whole world as evenly balanced between merit and sin, and think, if I do one more righteous deed, I might tip the balance of the entire world towards righteousness. So it's not that we shouldn't be thinking about the macro level, but can you do something like cause one person to die in order to save others? And there Judaism seems to say no. You can't, the famous trolley problem, you can't actually divert the train to kill one person in order to save the five. And so I guess that's the limitation that we've got here. And that's why I think that ultimately there's a hubris to thinking that we can anticipate all the things that will result. Obviously, we do care about politics, and we do care about politicians having proper policy that will affect the most. But we also wouldn't want politicians to lead us into things which are rankly immoral and violent towards the few in order to benefit the many. That would be a violation of the protections that we've got, for instance, in the Constitution, which wants to prevent the tyranny of the many over the needs of the few. And so there too, in politics, there's got to be a balance.
So let me just briefly respond to the broad question. I agree with much of what Rabbi Nevins said there. So I think, and there's a colleague of mine who I think is on this webinar, and she and I are writing about the very rich tradition and corpus that theology can bring to public policy, right? So we actually don't think that they need to remain separate. What matters is how that interaction happens, what the right language is, and what the right framework is. There was a reason why I started my talk today by presenting a framework, a public health ethics framework, and identifying what some of the core values are. Those core values come from a number of places. Theology is one of those places, right? So I do think it is incumbent on people of faith who have deep and robust faith traditions to help their representatives understand what their values are, what is important to them, because if those politicians, and I'm using small p politicians, right? I mean, in some ways, any institution has, politicians, but the people making those public policies need to understand what is important to their constituents. And sometimes what we find in secular bioethics is that the places that we've gone off the rail, so when there is a bad law that is passed, it is often because those who wrote the law wrote it in service of one set of values and didn't consider the competing set of values, which also needed to be addressed in thinking about the particular policy. So I think we need both. We need secular bioethics, we need the input of theology and values. The trick is knowing how to do that interaction, and that's not so easy to do, I will say.
Great, thank you so much. We're going to turn now to some Q&A from our participants. Rabbi Resnick will present the questions, and people are still encouraged to add some.
Thank you. Okay, so the first one is how do you think of, how do advanced directives and preference of patients factor into triage decisions?
So I can answer that relatively quickly. So if an individual has an advance directive that indicates that that person would not want one of these technologies, so for example, has said in an advance directive that they do not want to be intubated, to be put on a ventilator if they are unlikely to get off, so it's different than being put on a ventilator for surgery, for example, then that immediately factors in. So what we recommend is that healthcare providers have essentially what we call at the VA a goals of care conversation with all patients who are at high risk of a life-threatening event, so that if their preferences are such that they don't want that particular therapy, then we don't have to think about possibly distributing it to them, right? So they're essentially out of the calculus by their choice, right? The challenge, and so usually advanced directives, not always, not when they're extremely well done, but usually advanced directives indicate limitations, indicate what individuals don't want. And so that can actually be very helpful. And so that it factors in that way, mostly. So essentially it will take an individual sort of out of the group because it is in correspondence with their preference. Now the problem is the opposite doesn't always hold. So if the opposite is true, if it says that I want aggressive care measures no matter what, because every moment of life is precious to me, providers may not be able to accede to those wishes in a pandemic like this where there is scarcity of those resources. So on one hand, it can be very helpful. On the other hand, this is where that reprioritization of values may have direct impact on patient preferences because there are other values that take priority here.
I would just add that the Israeli document that I mentioned notes that there's a presumption that people want to live. And so that's sort of your starting point. But of course, ideally you have an advanced directive, or you have a medical healthcare proxy who has discussed these issues with the patient beforehand, and not only on COVID related, but all medical questions.
So thank you. I don't know how you would respond to this, but there's one question here from Elise Perlmutter, who is saying, as a psychiatrist, she's wondering if you have any thoughts about how to help colleagues make peace with the medical decisions that are so agonizing. And
yeah, so I will say that, this is a different talk, and I didn't have time to get into it, but moral distress among healthcare providers is real, right? And so moral distress is a situation where you know what the right thing to do is, but you are prevented from doing it for some reason. And it originated in the nursing literature in the early 1980s, and then has been widely distributed since there. There are other terminology people use, moral injury, that sort of thing. There's also simply the concept of distress, right? And so it is different to be, for example, the nurse that I described holding the hand of a dying patient as she dies, because her loved ones were not able to be there with her, and the nurse feels like that visitation policy is morally unjust. That would be a case of moral distress. That's different from a situation where, in the exact same situation where the nurse is holding the hand of the dying patient, but feels as though the visitation policy is justified because, for example, suppose it's what we call a congregate care community, so it's a nursing home. So there are lots of people who are at high risk. The nurse in that case might be very distressed on behalf of the patient that the patient could not have her loved ones with her, but it's not the same as moral distress. Either way, it is very difficult to address. One piece of addressing moral distress seems to be reminding providers that even when we are shifting the priority of our values in a public health scenario, we're not giving up our values. We are still acting according to core values. It's just which values take priority change. So for example, instead of prioritizing something like respect for autonomy, we prioritize transparency so that we make sure that we are being very clear with everyone about how we're making decisions and who is making them and why. And so there is, I think, some comfort in knowing that it's not all sort of fly by the seat of your pants, that there are core values according to which we're operating. The other thing that we've been emphasizing quite a bit is self-care, right? A colleague of mine who's also a psychiatrist is fond of saying, none of us are okay. Even those of us who thankfully have remained physically healthy, we are all self-isolating times 5 months, and the cooking, right? And everything else that we have to do that we don't always do, right? We had to completely change our lives. And so even those of us who are healthy are not okay. And so we've got to not only prioritize self-care, but think about innovative self-care mechanisms, right? You can't go to the gym, right? You could run outside. What are other things that you could do to help care for yourself, for your family? Now that school is starting back, right? But not going back, right? So how are we caring for each other? So I think with my staff, how do I care for my staff who are parents, who are now also school teachers and hall monitors, as someone said the other day, and all of that sort of thing. And so I think recognizing and remembering our shared humanity is another way, and being kind with yourself and kind to each other is another way of addressing the distress that healthcare providers feel, but that we all feel in a different way.
I would just add that pastoral care is also an important resource. I see in our participant list a number of prominent chaplains, and they're doing incredibly important work. And it's not only for people who self-identify as religious, and it's really they're there to hold the hands, even if they can't physically hold the hands, with the patients and with the medical staff. And there's been some beautiful articles written about some of our colleagues who are working with with doctors and nurses, and just helping them sort of recover their sense of their own resources, their resilience, their sense of guilt and grief over what they've experienced and decisions that were made. And also sometimes the impact on their families. We've got a lot of medical care workers who have to live apart from their families during this difficult time. They don't want to expose their elderly parents or their children and so on. And so they're giving a lot of sacrifice and maybe feeling guilty about it, or feeling guilty when they take a break and go back to their family. So those are very real, and it doesn't help anyone to create this hero type of image that we've got, just suck it up and keep going, because that leads to collapse and to demoralization, and it doesn't help anybody. So the self-care that Toby mentioned is really important.
Thank you. So we're nearly at the end of our time. In fact, some people might even say that we're over. But I want to, I think what I'm hearing from both of you is that there is a great need for each of us to be planful, resilient, and compassionate with each other. But that each of us is constantly balancing what's happening right before us and the larger social issue, and we're all making decisions around healthcare and lots of other things that have to balance all of those. Is there one thing, like either a piece of advice, something that's keeping you personally going in this time, that you might want to share as we leave, as your last word, but something, either about how you'd like people who spent this time with us to be thinking about these issues as their one takeaway, or something that's kind of your mantra as you balance them yourself?
I'll go first, I guess, right? Gives you another 30 seconds to think. I would say, it's a bit of a truism, but that it is okay not to be okay, right? And I think the operating assumption that our background condition normally is that we are, we're all we're typical, we're normal, we're all engaged, and a few people have stuff going on that makes life difficult for them. I think what this pandemic has done has flipped that and has recognized that humans are complicated, right? Families are complicated and interactions are complicated, and that even those who seem well adjusted, who seem to be interacting and working okay, are struggling. Everyone is struggling in a different way. And so I think what you mentioned about being compassionate, and what I say to my staff is start by thinking like an ally, right? Don't start by, oh my gosh, how could Rabbi Nevins have done X? Start by thinking, I wonder what Rabbi Nevins was thinking. I wonder what Rabbi Nevins is going through. I wonder what's going on there, right? And maybe even go to the next step and engage in conversation and say, I want to do a check-in. Are you okay? I'm just worried about you, right? And so being kind with others and kind with yourself.
It's very beautiful. I would just sort of take into account the themes of the season of return, of tshuva, and specifically Psalm 27, which we say morning and night for 40 days, actually a little bit more than that. And I think this psalm is about the poles of our emotional lives. In one moment feeling impervious, like, can't touch me, I'm up on a rock, my enemies may surround me, but they can't touch me, to dread terror. Why have you abandoned me, God? And I felt that personally, after COVID, I was like, oh, I'm impervious. I could just walk around without a mask. I don't. And I did read the case from Hong Kong of the reinfection. Although, as my father pointed out, that's one case in 14 million. So, okay, but still, don't be an idiot. And I get it. But at the very end of that psalm, we've got these beautiful lines. Lulei hamanti l'ropatu b'nai beretz chaim. I wish I could, just see the goodness of God in the land of the living. Because so often it just doesn't look like goodness is triumphing. There's disease, there's war, there's cruelty, there's hatred, there's irresponsibility, which we see so much of in this country. People feeling that their need to go unmasked to a bar is more important than the public well-being. And so I wish that I could see it that way. But then it says, "Kavel Adonai chazak v'yametzibecha v'kavel Adonai." You have to have hope in Adonai, in the Lord. And you could read that as, there's this anthropomorphic God up there that's just going to make everything okay. But that's not how I read it. I think it means have faith in goodness, in righteousness, and the importance of doing the right thing, which is what we associate with God, with godliness. Be strong, strengthen your heart, and have faith that you can actually make a difference. And I think that's what the whole bioethics discourse in this session today is all about, looking at the specific challenges, identifying what our resources are, our moral, our ethical resources are, figuring out how to implement them with most impact, and then having trust. Yes, Yoni, having some trust that if we live righteously and we do the right thing, then we do turn to God, because we cannot hope to control everything in this world. And we hope that God will also bring goodness to pass in our world. So I thank you for my part and wish you all Shana Tova.
Shana Tova. Thanks to each of you for bringing your wisdom and faith and focus to our session today and the work that you do every day. Thanks to everybody who joined us. We will send out a recording, and we welcome any ideas. You will hear from us again. Thank you and have a wonderful day.
Thanks, everyone.